during the 1980s, there became a real stigma to dying. Even though we're all going to do it, somehow there was a huge stigma. And suddenly doctors thought they were going to cure everybody of everything, and it was a physician failure if someone died. Prior to that, we had kind of accepted it as part of life. Now, it doesn't matter what a physician tells you, we are all going to have a life that ends at some time. And so when we talk about dying, there are certain patterns that people exhibit towards the end of life if we don't intervene. So when we talk about somebody dying naturally, we're talking about somebody whose life is starting to dim. And what you see with people who are dying without intervention from medicine or healthcare, someone who's aged, someone who has lived a good life, someone whose life is dialing down, is there are some real things that start occurring. And they can occur up to easily a year before someone's life is over. One of the things that starts happening with people is people who are normally very gregarious and very involved in other people's environments is they start withdrawing from the environment. And you see this in nursing homes, you see this in patients' homes. Granny, who was always baking cookies for everybody or always involved in everything every grandchild ever did, suddenly is not real interested. Now, unfortunately, rather than recognizing that she is dimming her life, we decide we need to rush her to a psychiatrist and put pills down her. And that's usually what you see happening to our aged as they are trying to dial their life down. They will even talk about it if you'll let them, and they'll say, you know, I'm ready. They want to do a good life review. They talk to you about the value of their life. They talk to you about the wonderful things they've done, but then they'll usually add a caveat, I'm tired. It's been a good run. Those are kind of terms that they'll use with you. Even your patients that are confused will start pushing themselves away from the table. They'll try to push food away from you. They'll try to push you away from them. It's a clear signal that they are trying to back away from life. And if we allow them to do that, then usually the next phase we see, if someone's oriented, they'll start giving away things. Now, I tell my children all the time, the day you start seeing me give away my jewelry again, you will know that I either have a terribly serious disease or I've decided to check out. Just be aware. So we can see clear classic indications. You know, mom who's constantly collected her china and has 5 walls of it in her home, and suddenly she's trying to disperse it. She's telling you that she's dialing down her life. Somebody who's been so attached to memorabilia and suddenly they're wanting to give it away. It's not because they've suddenly not become a hoarder. It's often because, again, they're dialing their life down. The things that have driven them to be engaged with life, baseball, their love of the Cardinals, their love of Mizzou, suddenly they don't care anymore. So what they're doing is they're stepping out of life. They're psychologically and physically stepping out of life. The next thing you start seeing people doing is that they don't eat or drink a lot and don't want to. And again, we usually want to go, oh, they're depressed. We need to get them on antidepressants. We need to force feed them. Let's get them on all these things to make them eat. People don't normally die stuffing their face full of food. So they start not wanting to eat or drink as much, being disengaged, and they will take to their bed if we allow them to. Now, this is an old rural term. Mom just took to her bed. But basically what that means is that they were done. And their body will literally take to the bed. The energy is not there anymore. They don't want to get up anymore. They're sleeping 20 out of 24 hours a day. Now, the next thing you notice with this person is they start talking to people you don't see. What we know now is that there is a phase between here and where somebody's going next that the rest of us can't visit yet. And depending upon your faith base, they might be seeing those people. We don't know. What I always tell my families is don't ever tell them they aren't there because you are not in that realm at this time. Because so many of my family and patients have seen their loved ones, what we do is we tell them to get them to talk to you about it. Who are they seeing? What are they saying? You know, if your faith base is the same with mine, this is the closest glimpse you're probably going to get to heaven for a while. When I worked in the ICUs, I had patients who had cardiac arrest, and I had one gentleman in particular who told me that he saw me doing CPR in his chest. Now, the reason I absolutely believe he saw this was because I had a particular word that I used when I was a critical care nurse when somebody arrested, and it's not a word I've ever repeated on videotape, and probably I shouldn't have said it. It's not part of polite society, but it had something to do with, oh gosh, I've got to get the crash cart. And he saw me, heard me say that word, and he said it with the same intonation I used it, a little louder than I should have also. It was not under my breath. And he saw me doing compressions on his chest. And this is what he told me. I had to make a decision. Where I was very beautiful. There was no pain. I wasn't having any difficulty breathing. I was so comfortable. And I saw you, and I saw the physician, and I saw them put a tube down my throat to make me breathe, and I had to make a decision to come back. And it took me quite some time to make a decision to come back because I wasn't sure I wanted to. I came back because I still had a small child. This was a patient who had a motor vehicle accident, and he threw a big blood clot to his lung. And he did die for us for a while. And I did think we were going to lose him. And he did come back, and it was a very difficult recovery. But when he was talking about being in that place between my reality and where he was going next and hovering there, I think that a lot of times our patients who are in the process of dying have that experience. And they can have that experience for a while. You'll notice that people who are verbal, who are what we call transitioning, that's a nice euphemism that we use in hospice, to talk about people that have got a foot here and a foot here, and they're kind of rocking back and forth a little bit, you know. You know, I'm over here where it's kind of prettier, but if I need to come back over here, I can. So we'll hear them start talking about or saying things like, do you see the path? What I tell patients, because I never lie to them, is I don't see it, but you can let me see it through your eyes. What does it look like? Share it with me. One patient who had not been verbal for years and had terrible dementia started asking me if I saw the path and was irate that I did not. Swatted my leg and said, you need glasses. This is a nonverbal woman with dementia for a number of years. I said, it sounds to me like you're on it. Head for the flowers. Go. She was dead the next day. I took care of another lady who was, we refer to them as lilacs and old lace in my trade. These are people who are obviously very loved by their elders, a matriarch in a family. This lady's home had white carpet, and I had to take my shoes off when I sat on it, and all of her white furniture had plastic, so nobody got any indentations on the sofa. Any of you all been in any of those homes? Where you felt like you needed to kind of scrub up before you came in the front door. And she wore little bed jackets, and her hair was blue, gray blue. Seen those folks? Okay. And she had been part of a very gentried group of people in the Jefferson City area. She had children, but her children said they weren't quite sure how they ever got here because mother never ever talked about how they were ever born or anything else because ladies didn't do that. And this very delightful lady had a terrible cancer. And she was very annoyed that she wasn't moving on anyway because she had been one of a 9-sibling group and they were all gone. And she said, my business here is done. I do not understand why I'm still here. And then at one point she was very, very upset. She was telling me about some great-great-grandchild, because this woman was in her late 90s, who was going to be born a girl and they thought it was a boy and weren't they going to be surprised. And come to find out that was absolutely true. And then she was very, very upset because the baby was going to be terribly ill. And that if the baby went back to heaven, there wasn't room for her. Now, the thing that was so interesting to me about all of this is her children had made no mention to her or any mention in the home about this child or the fact that the child was ill. So, as I'm explaining this to her family, because they lived in an environment where even though the children did not physically take care of Mama, them was always in the house with her. They had private duty caregivers around the clock to take care of her bodily functions because mother never exposed herself to children and didn't believe anybody else should see any part of that to her either. You know, nurses were for that, not her children. And then one day I went in to see her, and she was patting me, and she said, "Oh, you've been such a nice little girl, but I won't be seeing you. The next time you're going to visit, I won't be here. I'll be gone." And I said, "Well, explain that to me." Because her vital signs hadn't changed, her color hadn't changed, nothing had changed about her except her. She was very happy. She was leaving. And she said, "Well, the baby's fine. It's going to go home, and then there's room for me. And I am leaving because I'm going to heaven." Now, I knew her 5 children wanted to be in the home with her when this occurred. And because of my practice, I had known that when elderly people tell you they're going to die, unless you get in the way and jump on their chest, that's going to happen in a short period of time, if you will listen to it and pay attention. So I called her children and said, "If you want to be here, this is what your mother is saying." Her vital signs are the same. She's not short of breath, but she tells me she will be leaving this weekend. So they came in from all points of the United States so that they could be her mama, and apparently she was quite annoyed because she waited till they were all out of the room before she died. They had seen no change in her whatsoever. They went to go have dinner in the kitchen, and she died. And that's the other thing I can tell you is a lot of people do not want to be watched while they leave this earth, and they will wait till they are alone. And so when families are determined to sit right over them and stare at them, they wait till you go to the bathroom. There's a book called Final Gifts, and anyone who wants to read about what end of life looks like for a number of people, I would strongly recommend that to you, because it talks a whole lot about what the end of life looks like. One of the things that we forget is that dying is a cycle of living. It's part of the evolutionary process. It doesn't have to be strange, different, or awful. It can actually be a window into something that you will experience at some time. What we always tell our patients, and we tell people on hospice, one of the things we talk about is, how do you want this to be happening? You know, this is going to happen, so what are your wishes? Tell me your wishes about your end-of-life experience. What do you want it to be? How do you want it to look? One of the things, there was a huge study done about what people wanted at the end of life, and the first thing they wanted was they wanted to be at home. Number one thing people wanted to be was at home. Of all the people who want to be at home, only 50% of them get to be there. At least 50% of the people either die in the hospital or in nursing homes. The second thing they wanted was to be pain-free. How many people get that? You certainly don't get that in an ICU. The third thing they wanted to be was in control. They wanted to say when they wanted their pain medicine, they wanted to say if they wanted to get up, they wanted to say if they didn't want to eat. They wanted to be in charge. How many people get that as they die? But what we have to do as a culture and as a society of health caregivers is to educate our families that dying is part of the life cycle and not something to be afraid of by them or by ourselves. Actually, dying can be a very beautiful celebration to a glorious life well lived. I have a friend who constantly sends me an email that says, instead of slipping out, I want to scream into heaven going, "Thanks God, it was a wild ride." So one of the things that I tell people all the time when we talk about end of life, when we talk about looking at somebody physically who's dying, is there's some physical changes you need to be aware of too. So when we talk about this reaching and talking to people you don't know, you're usually a week or less out. People don't usually do this until they are within a week of end of life. So 2 days to a week you should be seeing this. Okay? They'll reach, they'll point. They'll talk to people you don't see, and again, you never correct them. Because frankly, you don't know if they're there or not. If they trust you, they'll share with you what they see. And then, like I said, it can be a real window into what could happen for you. And what a gift. Look at it as a gift. The next thing that you'll start seeing them do is you'll start seeing them having a change in breathing. They will become less responsive to you. They will start having a change in breathing. And there's 2 kinds of breathing that people, when they're dying, have. The first is Kussmaul's. And Kussmaul's is a cadence of breathing where we're fast and slow, and fast and slow, and fast and slow. Okay? Then the next kind of breathing people have is something called Cheyne-Stokes. And that's where we escalate, de-escalate, and protract. So that looks like if you don't prepare your families for that, that can be very scary. That can go on for several days. So 2 days out, you can see these respiratory changes, but you are usually within 48 hours when you start seeing these respiratory changes. The next thing you'll start seeing is secretions, and people call this a death rattle. In a real reality, it's not a death rattle. What it is, however, is people are losing their ability to control their neck muscles by secretions. Now, what do you do about that? Well, on hospice, we have medications we use, but what you can do is make sure their head is up and that they're positioned so that their jaw isn't lolling. So sometimes that's sideline. Understand that that sound is much, much worse for the family than it is for the patients. All this is an indication that we are closer on the path to end of life. They are not suffering with this, but sometimes the people who are listening are suffering. And so on hospice, we try to do something about that. We use 2 medications. One of them is collagen patches that helps drive secretions, and the other one is something called atropine, which helps drive secretions. But those are the things we use to try to control that particular behavior. The next thing you will see is you will start seeing changes in coloration. Now, we can have, based upon somebody's blood pressure, where their feet get blue and cold and their hands are a little blue and cold, but when you are seeing death-producing changes in coloration, they come and they stay. It's called mottling. And first of all, you'll get coolness, and then you'll start getting a slight blue, and then you'll get purple, and it'll creep up from fingers and toes up the body, okay? Because what's happening is the body is shutting down and going to the core. And so because of that particular issue, you're shutting down and going to your core here in your trunk. And then eventually, you will just stop. People hear to the last moment they take a last breath. One of the things we teach people about dying is, first of all, they can hear everything you're saying. And if you all start fighting over the bed, you all as being family, it can pull them back up out of their end-of-life experience. When I first started doing hospice, I had a unique experience with a lady who had 25 living children. She had started having children when she was 15, and she had 3 husbands. And her children, a lot of her half-children, didn't care alike for each other. And this was the kind of family that settled a lot of its disagreements with guns and alcohol. So at one point, as we thought she was comatose in her daughter's back bedroom, 2 of the half-brothers decided to get into a verbal altercation over her bed and started using a lot of profanity and threatening one another. Our patient, who had been comatose, we thought, for 4 days, sat up in bed and said, "Shut the, and it rhymes with truck, up here, I am trying to die." At that point, the children did take themselves outside. But the children who had been very skeptical of me telling them that your mother can hear you to the very last moment, the very last breath she takes, were no longer skeptics. And they were embarrassed and ashamed, which I think they should have been. But I was surprised, actually, that these 2 particular gentlemen had any shame about their behavior. So very clearly, people who think they've gotten here too late don't. Another gentleman I took care of, his granddaughter was in Europe. And he had not wanted her to go to Europe because there was some conflict going on over there at the time, and he was fearful for her safety. And he had requested that she not go, and this was his favorite granddaughter, and he made no bones about the fact that he had 5 and she was the favorite one, and he didn't care what anybody else thought. He kept what the family thought was hanging on. One of the daughters had pulled me aside and, "Why won't Dad go?" And I said, "He's waiting to make sure she's on U.S. soil. He needs to know for sure that his granddaughter is safe." So as soon as she hits the tarmac in New York, have her get on a phone and tell him she's in New York and she's okay. I think then he'll feel safe and it'll be okay to go. So that's what we did. They held the phone to his ear. They said he smiled, took one breath more, and he was gone. There is a whole lot of emotional work that goes with dying. And we can make it peaceful for people, or we can make it very disruptive. Now, when we talk about what hospice does, when we start talking about hospice and what it does and how it can help people who are at the end of life, first of all, the big concern people have for hospice patients or for people that sign up for hospice is, oh my God, that means I'm dying right now. Well, now it can mean that if you wait till the very last moment. But I've had patients on hospice with me for as long as 4 years. So hospice is for people who have a life-limiting illness with a prognosis of 6 months or less, who can't have or don't want any more aggressive therapy. But that doesn't mean they're dying today. And in fact, hospice is all about living your best life until you do die. So our focus is more, how can I help you have a better quality of life? How can I make you feel better? How can I make the days you have more joyful? What do I need to do to help you repair your relationships with your family? Is there anywhere you need to go? Anything you need to do? How can I help you do that? That's what hospice is more about. We acknowledge that there's a possibility that at the end of our relationship, death is going to occur, but how can I help you today? You know, we don't have very many Ozzie and Harriet families in the United States. I used to think that growing up that nobody else's family was crazy but mine. And after doing hospice for 19 years, I know that's not the case. And what I can tell you is a lot of people have great emotional angst. And it's very hard to die when you're having terrible emotional angst. You need to resolve and have some levels of peace. And so with the help of our chaplaincy and our social work group, we can help support and bring some peace. The next thing hospice tries to do is find out what are the 5 things that are most important to you. We talked about some of them. Dying in my place of home that I identify as home, being able to refuse treatment, choosing my physician. You know, for you it might be having peaceful music. For some people it may be rock and roll and heavy metal. And we try to create an environment for you where that's going to work. One of the things that we try to teach our families is that hospice is not just for the patient, it's also for the family. Because our culture has created such a negative perspective of what dying is about, it's our job to reverse that process and let them know that it can actually be a celebration of a passage of life. And so we really work hard at trying to do that with people. It's very, very interesting, though, what people define as a good death. And it's different based upon each and every human being. And also based upon culture, religion, ethnic groups. And so one of the things we struggle with as we talk about dying is, what is it identified as for that patient? How do they identify it? I was telling some of you all later, hospice isn't for everybody. Even though you know that you have a patient that's at the end of life, it may be that they are planning to struggle against whatever disease process is actually taking over their body till the very end. And that kind of person isn't appropriate for hospice. And you have to also honor those wishes as well, even though you're looking at some fairly futile treatment. But it's nothing to be afraid of. And it actually can be an event to be embraced and enjoyed if you know what you're looking at and how to help. Now tell me what questions you like.
I do have a question for you. I know as private duty home care workers, we're in the home with people that are at that borderline sometimes. They're getting close to dying. And when is the point where we should refer them to hospice?
Well, anytime you have a patient who is declining in condition, there are some real triggers for what is appropriate for a hospice referral. One is that you have weight loss. In any disease process, if you're having unintentional weight loss of greater than 10%, that is usually an indication that somebody's having significant decline. Another one is if you've had a decrease in functional ADLs, and not because of an injury, but because somebody is just declining. An alteration in mental status. Somebody was able to communicate in full sentences to you and make sense, and now they cannot. With dementia, if you take care of a dementia patient at home, it's a fast of 7C. And a 7C fast indicates that somebody's incontinent of bowel and bladder. They can only say probably 7 intelligible words. They need assistance in all of their ADLs. With somebody who has COPD, they're oxygen dependent 24/7. They can't walk across the room without getting short of breath. And they maybe have tupilla dyspnea when they sleep. For heart disease patients, it is when they have resting episodes of chest pain, and any sort of exercise or any sort of activity makes them short of breath, and they have recurrent episodes of edema. And anytime any of your patients are having recurrent hospitalizations, it's time for conversation. Now, when you talk about hospice, it does require a doctor's order. That doesn't mean that I can't come talk to somebody who wants to have hospice about whether or not they're hospice appropriate. So for instance, you could say, I want you to come talk to me about hospice and whether or not it's appropriate for me or appropriate for my husband. And I can talk to you about that for an extended period of time. I, however, cannot admit you to hospice without a doctor's order. Now, if I strongly feel like you're appropriate and you want to be admitted to hospice and your doctor doesn't want to play, I can ask my medical director to come out and assess you for appropriateness. Most people will not do that because they have tight relationships with their physicians and they want to be compliant with their doctors. And frankly, there are some doctors who do not believe in hospice care because they do still believe they're going to save everybody. There's also the fallacy that if somebody goes on hospice, they can't continue to see or treat their patient, and that's not true at all. Hospice does not take away somebody's own private physician, nor do they take away the right of that private physician to treat. There's also another fallacy that says that if you're on hospice, you can't go to the ER, and that's not true either. You can. So there are a whole lot of fallacies about hospice restricting what people can do medically that are not true at all. Hospice is supposed to be, and the way it was designed, is supposed to be for the patient and for the family. It is supposed to be under the hospice care is supposed to be under the direction of the patient, and when the patient can no longer speak for themselves, the person they appointed is their spokesperson. It is not supposed to be under the direction of a physician or any of the hospice team. We are supposed to be there to be the guide to someone for their end-of-life care. We're supposed to offer options and choices, but we don't make the decision. That's how hospice is supposed to be. Unfortunately, there are agencies that don't provide hospice care in that way. And people need to be buyer beware with hospice anymore, and I will say that very honestly. I think people who are thinking about hospice care need to interview hospices. They need to talk about goals of care, and they need to interview more than one. Because your physician works for a hospice company is not necessarily a good reason to be seeing him or going to that hospice company, because you need to ask yourself, what does your doctor have? You know, what has he got in the race? Maybe that's not the best hospice company for me. You need to check references. Who else has had this company? Have any of my neighbors had this company? Did they have a good result? Somebody who's going to be playing totally above the line with every patient and family they see lets them know on the very beginning of what we call a hospice introduction. They let them know how many other hospices are in their geographic area, that they certainly have a right to choose any of the hospices they would like, that they have a right to interview all of them if they would like. They have a right to ask questions about why would I choose your hospice over another one, and they have a right to say, what about these circumstances? Ask them, do they triage on the phone? Or do they come to see you when there's a change in your loved one's condition? When you say, I have 24-hour access to you, what does that mean? Does that mean you're going to answer the phone, or does that mean you're going to come help me? So there are a lot of things that people can ask. And whether or not your doctor works for that hospice is not necessarily the good one to ask. Other questions? Have any of you all had anything to do with anybody on hospice?
Mm-hmm.
Oh, yeah.
I hope it was a good experience for you. I'm prayerful it was, but more importantly, I hope it was a good experience for your families. There's an old saying, one negative destroys the last 6 months of positives. And one bad experience, it takes 6 positive ones to make up for it. So we're constantly striving to make sure that we are that positive experience. Okay. Thank you
so much.